Hi, everybody. My name is Kera Nolly. I am a veterinary dermatologist, a diplomat of the European College of Veterinary Dermatology. And I am very happy to present you a lecture on how to approach a pruritic dog. And we're going to start by presenting the case of Boston. Boston is a German Shepherd. He's a male intact of 4 years of age, and his weight is 35 kilos. He was acquired from a breeder at 4 months of age. He has been regularly vaccinated and dewormed, particularly when he was small. Flea control is only in the summer months, from June to September, 3 months. He is the only animal at home, and the owner is very nervous and unhappy because he has pruritus the whole year round since the age of 18 months. And he also has seasonal exacerbations. Now the dog also has developed a little bit of bad odor, and the owner has already tried many things. He has tried several diets with no improvement. He has tried several drugs for pruritus, for example, cetirizine with no efficacy. He has tried prednisolone and there was a temporary improvement, but when he stopped the prednisolone, the disease would come back. So he was very, very unhappy about the whole situation. I would like to show you the impact that pruritus has on the quality of life of the owners and of the dogs. The first line is the correlation between pruritus and the quality of life of dogs. And there is a significant inverse correlation. And the second line is the correlation between pruritus of the dog and quality of life of the owner. And here also we have a significant inverse correlation. And we see that he has erythema and hyperpigmentation in the inguinal area, but also in the axilla. He has erythema and hyperpigmentation and also some greasy material in the interdigital spaces. In the image in the center bottom, that is a hotspot, and that is a pyotraumatic dermatitis, is a humid spot that the dog is chewing because he has pruritus in that area. And that hot spot was localized on the hips. And he also has this brownish material at the nail bed, at the basis of the nails. And he's also licking very much in his toes and in his interdigital spaces. So if we have to summarize the list of problems of Boston, he has pruritus on the muzzle, in the armpits, the groins, the paws. He's licking, chewing, but he also has pruritus at the tail basis because he has this hotspot. He has erythema in these areas. He has a brown discoloration of the nail bases, hotspot. And one of the problems is that the owner is very, very nervous. He is impatient to find a definitive solution for the problem of this dog. So we have to act quickly in this case. Now, after having seen the whole list of problems of Boston, we have to write down a list of differential diagnoses. And obviously, we have a dog that is not very well protected against fleas and parasites, that has hotspots, that is the typical lesion of flea bite allergy on the dorsolumbar area, and he has a seasonal exacerbation of his pruritus. So flea bite allergy certainly is one of the differentials. We have to think of other allergies like adverse reaction to food or atopic dermatitis. And again, because he is not very well protected by antiparasitic drugs, we have to consider parasitic diseases like sarcoptic mange or other parasites. And we also have to consider secondary infections because of the bad odor that Boston had, because of the brownish discoloration at the basis of the nails, which is typical of Malassezia pyrrhonychia, and because of this material between the toes that is also typical of bacterial overgrowth. So let us consider a little bit this possible differential diagnosis. Flea bite allergy is usually seen in adult animals. It starts, let's say, between 3 and 5 years of age, and it should not be excluded if you do not see fleas or flea dirt, because allergic animals are so disturbed by the presence of fleas that they are very able to rapidly eliminate these fleas by ingesting them. You see on the left image the flea dirt, and you can put these small black dots that you will find on the coat of the animal on a wet cloth. And if you see the production of a brown halo around this material, then you know this is flea dirt and you know the animal has fleas. Usually, the signs of flea bite allergy are seen on the posterior side of the dog. You can see signs of pruritus and erythema and papules on the abdomen. You can see scratching and alopecia on the back. You can see hot spots. The left, the typical aspect of a severe flea bite allergy, where you see self-induced alopecia on the dorsolumbar area. In the middle, you see erythema also in the perianal area and in the medial legs. And on the right side, that small image, you see the typical hotspot, which is a self-induced lesion due to violent, acute chewing and damaging the surface of the skin. And usually you see these lesions in the back dorsolumbar area, like we have seen in Boston. The second differential is adverse reactions to food. And you have to know that usually dogs are most frequently allergic to chicken, to bovine meat, and to dairy products. Of course, this is a non-seasonal allergy with pruritus, and in many of these cases, we also have gastrointestinal problems. We may have soft feces, we may have vomit, we may have flatulence or borborygmi, and usually it can happen in younger animals. It may even be seen in animals that are younger than 6 months of age, but you can see food allergy in any age, even in older animals. Then we have atopic dermatitis, and this is the allergy against environmental allergens. So usually we can see it against pollen, molds, mites, or epithelia, like the cat epithelia. Depending on the allergen, it can be seasonal, like the pollen allergen. And by pollen, I'm thinking of tree pollen, grass pollen, weed pollens. But it can also not be seasonal. For example, the allergy against hostess mites, like the image you see on the left side, that is mites from the house dust of my house. We usually see the initial lesions and pruritus when animals are between 1 and 3 years of age. Some very severe cases can start between 6 months and 1 year of age. So food allergy and atopic dermatitis, they are very similar because clinically they have erythema, pruritus in areas that are the extremities. For example, you see on the right-hand side the forefoot and the hindfoot, and mostly we have problems in the interdigital spaces or on the medial areas, like in the top right image of the feet and of the legs. We also have problems in the ventral areas of the body. On the top left image, we see a groin, but we also have problems in the axilla. And we may also have erythema and pruritus around the lips, the muzzle, and around the eyes, like you see in the image on the left bottom. And so here you can see the localization of the three main allergies in dogs. Number one is adverse food reaction, and you see the extremities, the head, the muzzle, the ventral areas, but also the dorsal areas can be involved. Number two is atopic dermatitis, environmental allergy. And that is very, very similar to food allergy, involving the extremities and the face and the head and the ventral areas. But we very rarely, if not never, have problems on the back in atopic dermatitis. Number three is flea bite allergy. And as I mentioned before, typically we have problems on the back, on the dorsolumbar area, and on the abdomen, like the posterior parts of the body. Now, all of these allergies can be complicated by secondary infections because the skin of an allergic animal is very much predisposed to developing pyoderma. The immune system is different, the skin surface is different, and the bacteria, they can take advantage, they can colonize much better, and they can cause bacterial infections. This can happen both on the areas of trauma for rubbing. You see on the right-hand side, this yellowish pus crusts around the muzzle of an animal that was rubbing a lot because of his allergy. But in dogs, we can also have the development of bacterial folliculitis, and we can have pustules or collarettes, like the picture in the middle. We can have multifocal alopecia, like in the image on the right-hand side. How do we diagnose bacterial infections? Well, we can use cytology. We can open the pustules and make an impression smear. The first two images, top left, if we have an erosion, we have an open lesion, we just make an impression smear from the exudate from this lesion, like you see on the top right image. And these samples, they are stained with the usual Diff-Quick or hematology stains. And you can appreciate in the bottom right image the presence of neutrophils. They have several lobules, they are multi-lobuled nuclei, and there are also many bacteria inside the cells, but also outside of the cells. And these bacteria in this image are both cocci as well as rods. So this is the way you will diagnose pyoderma. But we also have Malassezia dermatitis. Malassezia are yeasts, and they can cause this very pruritic, erythematous, greasy dermatitis. We have like waxy crusts on the body, and we also have this brownish material at the basis of the nails with this paronychia. How do we diagnose Malassezia dermatitis? Well, the best way is to use sticky tape because it can collect very good amounts of Malassezia. And you can also use the sticky tape in areas where it is difficult to use a glass slide, for example, the interdigital spaces or the skin folds. And then you stain the sticky tape like you would stain a glass slide, and you look at it under the microscope, and top and bottom left, you will see the aspect of the Malassezia. They look like peanuts or footprints. They are much bigger than the bacteria. And we should not forget that we also have both in food allergy as well as in atopic dermatitis, inflammation and infection in the ears. So the vast majority of the cases where we have an otitis, the underlying cause is actually an allergic disease. And the otitis can be mild, erythematous, can be severe and chronic, can be ceruminous, can be purulent, and we also perform cytology of the exudate to understand if there is an infection, and if so, what are the microorganisms involved in this infection. But now let's go back to Boston. So what did we do? We did ancillary testing to try to understand if there were infections in Boston. We did an impression smear from the hotspot, and we found a mixed bacterial population. As you can see in the image, there are many bacteria of different shapes, but there were no neutrophils, so this was a bacterial overgrowth. That means that there is no need to give systemic antibiotics, that you can treat this lesion just with disinfectants. And then we did a clear cell test from the interdigital spaces and from the nail bases, and in fact we did find malassezia in these areas. As you can see from this image, they look like peanuts. So if we want to update the list of diagnoses in the case of Boston, we know he has a bacterial overgrowth on the back, and that is the hotspot. He also has a pododermatitis and a paronychia with malassezia, and these are secondary infections, and the primary underlying disease, as we have mentioned before, it could have been a flea bite hypersensitivity, a food allergy, or an atopic dermatitis. So how do we proceed in these cases? Well, we have a very well recognized systematic way to approach these cases. First of all, we should take into consideration and eliminate ectoparasites infestations. Then we have to look for infections and treat them. And then we have to look for food allergy. And if we don't find any food allergy, then we can say that we have diagnosed an atopic dermatitis. I'm going to show you one by one what we did with Boston. So in order to treat the parasites, we actually used a very good broad-spectrum oral antiparasitic drug, Fluralaner. We give it once and it will kill every parasite for 3 months. For the infections, we gave a chlorhexidine foam every day in the interdigital spaces and in the nail beds in order to kill malassezia. And we used the same chlorhexidine foam also on the hotspot in order to kill the bacteria. In order to evaluate if the underlying allergy was a food allergy, we also gave a hydrolyzed hypoallergenic diet, and you have to know that the minimum number of weeks that you have to give a hypoallergenic diet is 8 weeks. We used Purina HA because it is a very reliable diet made of hydrolyzed soy and starch. It is important that the hydrolysis is of low dimension. It is important that in these hypoallergenic diets, there is no whole cereal, but only starch, because cereals also contain proteins. It is very important that the diet is given exclusively for 8 weeks with nothing else given. For example, no dental sticks, no chews, no, we have this skin bones or anything from the table. Because Boston had pruritus and the owner was very unhappy and frustrated about this, for the first 2 weeks of the diet, we also gave something against pruritus. And so we gave prednisolone at about 1 milligram per kilogram. Boston weight 35 kilos, and so we gave 40 milligrams of prednisolone to Boston every day for 2 weeks. And then we asked to stop and we wanted to see Boston after another 2 weeks where he would have received only the diet and no corticosteroids. So just to mention the importance of the use of hydrolyzed diets for the hypoallergenic diet. We do know now that there are several cross-reactions between the different proteins of the different species. So even if we use a limited antigen diet, we will never be really sure that this animal does not react to the protein that is in this limited antigen diet, even if he has never eaten it. We also know that in limited antigen diets, there are contaminations. There are several studies that have proven that there are proteins in these diets that are not mentioned on the label. So the dermatologist recently considered that the most reliable way to perform a hypoallergenic diet is to use a hydrolyzed diet where the proteins, and you see the protein chain in the image, are cut in very small pieces, in peptides or single amino acids that are too small to be recognized by the immune system, ideally below 5 to 6 kilodalton. You can see in the image on the bottom right a mast cell. The left mast cell recognizes a large protein, and the bridging of two IgE molecules on the surface of the mast cell, recognizing this large molecule, is the trigger for the mast cell degranulation. But on the right side, you will see that if the molecules are too small, they will not be able to cross bind these two IgE molecules, and because this bridging of the two IgEs is not happening, there will not be the triggering of the degranulation and the initiation of the allergic reaction. So after 1 week, I had a telephone with the owner of Boston, and he was so happy because one day after the first prednisolone tablet, the dog stopped scratching. That is quite obvious. That was what we were expecting, but he was happy, and the dog and himself can now sleep well and are both more relaxed. The dog eats the hypoallergenic food very well. On the one side, because Purina HA is known to be very palatable. On the other hand, if the dog is taking prednisolone, his appetite will increase very much, and so he will accept the diet much better. So these are the images of the follow-up, and you can see that with time, these lesions are improving from erythematose. They are getting less and less erythematose. This is the groin. And the same is true for the axilla. You see this erythematose, hyperpigmented color is going away. The image in the middle is the one after 2 weeks, and the image on the right side is the one after 4 weeks. This is the interdigital spaces. They have also been cleaned and disinfected with the chlorhexidine foam, and he is improving here too. And the same is true for the nail beds. You can see that the nail is growing white again, and that means that the Malassezia paronychia has been eliminated. So we saw Boston after 4 weeks, and he had taken the diet very well for 4 weeks, and he had also taken the prednisolone in the first 2 weeks. But unfortunately, at the end of the 3rd week, so 1 week after stopping the corticosteroids, there was relapse of pruritus. But everything else was well, there were no infections anymore, and then I said they could then taper and stop the treatment with the chlorhexidine foam, but they had to continue the diet for another 4 weeks because, you know, the diet should be done 8 weeks in total. And in order to help a little bit the pruritus in the following 2 weeks, I prescribed to try oclacitinib at 0.5 milligram per kilogram, so 1 tablet of 16 milligrams for every 12 hours for the first 2 weeks and every 24 hours for the third week, and then stop it completely because I wanted to have the last week of the diet without any drug. I wanted to be able to evaluate the effect of the diet alone on the last week of diet. Then he came back after another 4 weeks, and what he said was that oclacitinib was working very well against pruritus, but as soon as he stopped the oclacitinib, the pruritus came back. He had no skin lesions, he had no infection, he just had pruritus. Now, having given a very good quality diet for 8 weeks, if he still has pruritus, then we have excluded the possibility that Boston has a food allergy, and in fact, we have diagnosed atopic dermatitis. And here we have a summary of the diagnostic process of what I have done with Boston. In the middle, you see the bar. This is the hypoallergenic diet. We have to do a trial for 8 weeks. If there are infections, we start with therapy of the infections. We start with an antiparasitic drug on day 0. We also start with corticosteroids, and we give it for the 2 weeks of diet. We evaluate then the dog after 4 weeks of diet. If the pruritus does not come back, then we may think that the dog has adverse food reaction, and we may start with the provocation test with the old diet that the dog was eating. But if the pruritus comes back, we have to continue the diet for another 4 weeks, because usually the diet is for 8 weeks. We can help the dog with oclacitinib in the 2nd month of the diet, but we have to stop the oclacitinib before the end of the diet, usually 1 week before. We evaluate the dog at the end of the 8 weeks of diet, and if there is no pruritus, we may think that the dog has a food allergy, and we should do a provocation test with the old diet. But if the pruritus comes back, then we know that the dog has no food allergy, because we have given an antiparasitic drug from the beginning of the diet. We also know that there is no flea bite allergy, so we have the diagnosis of atopic dermatitis. So let us talk a little bit about atopic dermatitis now. Atopic dermatitis is a multifactorial disease. There are many factors that contribute to it. We know that there is a genetic predisposition, there is a skin barrier defect, there is a hyperreactive immune system, there is, of course, the role of the environmental allergens. We have seen mites and molds and pollens. We have seen that we can have secondary bacterial and yeast infections, and we can also have parasitic co-infections, particularly fleas. We also can have flea bite allergy that are deteriorating the signs. Now, we can do something about the majority of these factors. Besides the genetic predisposition that we cannot change, we could stop breeding predisposed animals. But if you have an animal that already has signs of atopic dermatitis, you can work on all other factors. And here is an overview of everything that we can do for atopic dermatitis. We can actually do more than one intervention at the same time, because usually these are multifactorial therapies. On the left side, we can work on the environmental allergens by trying to avoid them, for example, the avoidance of fleas or of food allergens, and by starting an allergen-specific immunotherapy, so that we create a tolerance of the immune system towards these allergens. We have a skin barrier defect, and we can improve the skin barrier. We can do that by using topical products, for example, spot-ons, sprays, colors, or lotions, but we can also use nutraceuticals and skin diets that are able to improve the skin barrier. If we have parasites, bacteria, and yeasts as secondary infections or infestations, of course, we can use antiparasitic drugs. We can use therapy in the ears if we have a bacterial or yeast otitis, and we can use systemic or topical antibiotic or antifungal therapies. Most importantly, because you remember that pruritus is impacting so badly on the quality of life of the owners and of the dogs, we have to do a therapy that will stop pruritus and inflammation. And we can use topical therapies like shampoos, pads, sprays, and creams that contain antipruritic and anti-inflammatory molecules. We can actually use nutraceuticals that will decrease inflammation, essential fatty acids, skin diets, PEA or CBD products, and of course we have a variety of systemic antipruritic drugs that we can also use. So how should we use all of these possibilities that I have just shown you? Well, there is an important strategy that we have to learn in the treatment of atopic dermatitis. We have two steps in this therapy. The first step is to get the acute flare in remission, and that is called the reactive therapy. Once we have got the flare in remission, then we want to maintain the remission and avoid the returning of the flares. And for this, we use a proactive therapy. So how can we get the acute flare in remission? What should we use for our reactive therapy? Well, we need drugs that are very potent and very quick in decreasing pruritus and inflammation. We can use corticosteroids, both topical or systemic. We can use oclacitinib, we can use lokivetumab. They are usually giving results within 1 or 2 days. Once we have the flare under control, we want to start the proactive therapy in order to avoid the returning of the flare. Well, we can use the same drugs that I have just mentioned, but some of these are quite toxic, and the proactive therapy should be performed for the whole life of the dog, because the allergy is a long life disease. And so certainly we do not want to give corticosteroids the whole life of the dog. So we have to find some alternatives that are efficacious to keep the flare under control, but that are also safe to be given for the whole life of the animal. So alternatives could be cyclosporin, antihistamines, nutraceuticals and skin diets, and topical therapy. And their use and combination will depend on the severity of the disease, on the localization of the lesions. So when we talk about corticosteroids, we know that they are very effective, but we can only use them for short periods, because they have a very broad spectrum of activity on the immune system, and so they act as very immune suppressive. They also have activity on every cell of the body, and they will cause side effects. They cannot be used in dogs with infections because they are immune suppressive. The same is true for demodicosis, and they will be a problem in dogs that have kidney disease. They can exacerbate the kidney disease. They are contraindicated in cases of diabetes and Cushing's. So we have to be careful. I usually use corticosteroids for a maximum of 2 weeks each time. I prefer to use corticosteroids by mouth, prednisone or methylprednisolone or prednisolone, and I start with a dosage of 1 milligram per kilogram per day for 2 weeks, and then I switch to some other drug for my proactive period. If you want to use corticosteroids as a proactive long-term therapy for economical reason of the owner, the maximum amount that I think that you can give for long period of times is 0.5 milligram per kilogram every other day. It is important to give it every other day and not every day for long period of times. These are some of the clinical symptoms of side effects of corticosteroids. You see alopecia, pendulous abdomen. In the middle image, we see very thin skin with evident vasculature. And in the image on the right, we can see the bruising, the hemorrhages, because there is a weakness of the vessels too. There is atrophy of every tissue of the skin and of the muscles. So we have to be careful about using the corticosteroids. A good alternative now is oclacitinib. It is a Janus kinase inhibitor. It is able to block pruritogenic pro-inflammatory and pro-allergic cytokine function. It inhibits pruritus caused by cytokine IL-31, which is the main pruritogenic cytokine. So you see here that of all of the cytokines, interleukins involved in the allergic reaction, oclacitinib is able to block all of them with exception of EL5. We had oclacitinib on the market already for 10 years now, and we know it's working very well. We should give it twice a day for the first 2 weeks. And here you see how the pruritus in this graph is going down very nicely from day 0 to day 14. And then we should give oclacitinib once daily for the continuation of the therapy. And once you give it once daily, you can have people that will complain because the pruritus is increasing again, as you see in the graph from day 14 to day 28. But then the efficacy is persistent. There is no loss of efficacy with time. Lokivet-mob is another good alternative. It is a purely antipruritic drug. It is not anti-inflammatory. So if you have an animal that has a lot of inflammation, this is probably not going to work as well as corticosteroids or oclacitinib. It is an injection. It is a caninized anti-canine IL-31 monoclonal antibody that will bind IL-31 so that it will inhibit the binding of this cytokine to its receptor. And as I told you before, IL-31 is the most important mediator of pruritus. So if it is blocked, it will not cause the sensation of pruritus. An injection will last for 1 month. In this study, where it was used in 135 dogs, 80 dogs with atopic dermatitis, 10 that had atopic dermatitis and food allergy, and 45 that had pruritus of undetermined cause, there was a good response in 77% of the dogs. It is probably not as effective as oclacitinib and steroids, but the good point is that it does not have contraindications and it has very minimal side effects with a little bit of lethargy seen in 8% of the dogs. There is no difference in efficacy for dose or body weight or type of allergy, although the animals that got a higher body weight had better results. Another alternative that I would use for the proactive therapy is cyclosporine. We know cyclosporine for 20 years, and it works really very well against all the cells that are involved in the allergic reaction, and particularly T lymphocytes, but also eosinophils and mast cells, Langerhans cells, and macrophages. Now, the mechanism of action is more focused than the one of steroids, and that means that the side effects are also less prominent. The efficacy is similar to the corticosteroids, and the doses that we use in dogs is 5 milligrams per kilogram per day. Now, the interesting thing about cyclosporine is that in some of the dogs, with time, we can decrease the dose, or we can taper the frequency of administration by maintaining the same clinical remission. So as you see in this graph, in the first month, every dog is taking cyclosporine every day. But in the second month already, about half of the dogs can take cyclosporine every other day without a deterioration of the clinical situation. In the third and fourth month, there are even some dogs that can take cyclosporine twice a week without a relapse, and many can take cyclosporine every other day without a relapse. So this means that for the long-term maintenance proactive therapy, we can, in many cases, have a very reduced amount of drug that is necessary to keep the remission under control. Now, the problem with cyclosporine is that it is very slow to work. In this graph on the left-hand side, you see the efficacy of prednisolone in decreasing CADESI, which is the lesional score, from day 0 to week 3 to week 6. And you see that the lesional score already decreases very well after 3 weeks with prednisolone. If you look at the graph on the right, this is cyclosporine. You can see that at week 6, the efficacy is very similar to that of prednisolone, but at week 3, cyclosporine is not working as well as prednisolone. So it is much, much slower to work than prednisolone or oclacitinib. And this is one of the reasons why I have not mentioned cyclosporine among those drugs that you can use for the reactive phase. So in this case, we think that in the initial phases of cyclosporine use, it is very helpful to add corticosteroids and have a concurrent administration of steroids and cyclosporine, or oclacitinib and cyclosporine for the first 2 weeks of therapy. And that would be our reactive phase. Then you stop the steroids or the oclacitinib and you continue with the cyclosporine that in the meanwhile will have started its efficacy, and here you have your proactive phase. So in every case I choose to use cyclosporine, I will always add steroids or oclacitinib in the first 2 weeks of treatment. Now, we can see some side effects with cyclosporine. We can see an immediate side effect, transient vomiting or diarrhea in the first days of treatment. And in this case, you can change the habits of the administration, give it on a full stomach versus an empty stomach. You can freeze the capsules, or you can add maropitant as an anti-vomit drug. Much more rarely, you have other side effects like the gingival hyperplasia, you can see in the photo on the left, or hirsutism, you can see the same dog has a mustache and a beard, or the development of viral papillomas, as you can see on the tongue of the photo on the right. All of these side effects are reversible as soon as you decrease the dosage or you stop the treatment with cyclosporin. What are other alternatives? Well, I have mentioned antihistamines. However, we only have very old and uncontrolled studies dealing with the efficacy of antihistamines, and the efficacy that has been published is very low. It is very similar to that of placebo, which is about 30%. The International Committee on Allergic Diseases of Animals, they concluded by looking at all of the studies on antihistamines that there is no evidence for their use in atopic dogs. So I have talked about systemic drugs. I would like now to talk about topical antipruritic and anti-inflammatory products, because these are very good for the proactive therapy. If they are effective, they can be given for a long period of time because they are very safe, because they are not systemic drugs, but they are topical drugs. One option is hydrocortisone acetonate. It is a corticosteroid spray that is not absorbed too much in the skin, and it does not cause too much of a thinning of the skin, because it is degraded in the very superficial layers of the skin. The efficacy is comparable to that of cyclosporin, as you can see with the decreasing of the Cadisi levels on the left. Cadisi is the skin lesions, and of the pruritus levels on the right. It may interfere a little bit with the skin testing, so you want to stop it 2 weeks before the suspension time. But besides that, you can give this for very long periods of time with no particular problem. For this reason, there is a study that has evaluated its value as a proactive treatment of atopic dermatitis, and it was given on the weekends. And you can see that dogs that were treated with hydrocortisone acetonate spray to avoid the relapse of the flare of the allergy, they had an average relapse time of 115 days compared to an average relapse time of the placebo dogs of 1 month. There are also non-drug ingredients that can have antipruritic efficacy, and one of these is ophitrium. It is a purified natural ingredient from a tuberose root of Ophiopogon japonicus, which is the plant that you can see on the right-hand side, dwarf lily turf. And this molecule has several interesting properties because it is an anti-inflammatory molecule. It is able to limit the release of pro-inflammatory cytokines by Th2 cells, and it helps restoring the barrier function that we know that in allergic dogs is disrupted. And ophitrium is present in shampoos, in mousses, in pads, and in lotions. So these are some antipruritic, anti-inflammatory topical options that can be used locally. And then we do have the problem of the barrier defects that we know that are present in atopic dogs. And we have also some topical products that are barrier restorers. So this is a little bit the scheme of how the skin barrier is formed. On the top right image, you have the epidermis, and you can see that the layers that are on the top of the epidermis, the stratum corneum, is made with like a wall with bricks and mortar. The bricks are the corneocytes, and the mortar between the bricks are the lipids. If we look at these layers of lipids between the corneocytes, we can see the color image in the center, that these are composed by molecules of ceramides, very long molecules, free fatty acids, and cholesterol. And they are all arranged in very ordered sheets. And on the right-hand side, you can see the chemical molecules of these lipids. You can see in the image on the left that these lipids are arranged in very ordered layers. The K is the sign for a keratinocyte, and the white arrows that you see, they show these lipid sheets between two keratinocytes. And this is the healthy situation. In the image on the right-hand side, these black arrows, they show the lipids that are arranged in a very unordered way. They are completely unorganized. There is also some amorphous material between these lipid sheets. And of course, this is a problem because these lipid sheets that should be sealing the space between the keratinocytes in the surface of the stratum corneum, they are not working very well. They will not be sealing the spaces anymore. And there we can have the entrance of allergens, of bacteria, of toxins that will cause the reaction of the immune system. So we can actually use topical products to improve these lipids of the skin barrier. We have topical sprays and lotions and spot-ons that contain fatty acids, ceramides, and sphingolipids. We know that they will improve the skin barrier. They will increase the ceramide content, reorganize the intracorneal lipids, and we also have an improvement of the lesions and of the transepidermal water loss. And here you have on the left and on the right the situation of allergic animals before and after the administration of these products. And you can see, particularly on the image on the right, how before the administration of these products, the keratinocytes are all disorganized, the lipids between the keratinocytes are missing. After the administration of these products, you see that the stratum corneum is much more similar to a healthy skin with very well organized keratinocytes and intercellular lipids. But you can help the restoration of the skin barrier and the inflammation also by using nutraceuticals. And there is a very recent article that has been published that is describing very well the efficacy of many nutraceuticals. And so this is an open access article, and you can go and look at it. It's very interesting. So how can we do a nutraceutical manipulation? We can give supplements, and mostly the typical supplements that we give are based on essential fatty acids, but we can also put all these supplements inside the diet. And so we have dermatological diets, and without giving extra supplements, by eating, the animal is taking all these molecules that are so important for the health of the skin. So when we talk about essential fatty acids, why are they so important? Well, they have a physiological effect because linoleic acid, which is an omega-6 fatty acid, is very important, is part of the cell membranes, and is also part of the intercellular lipids of the protective lipid barrier. And so it will improve the barrier function, it will improve the skin and the coat quality. But essential fatty acids also have a pharmacological and inflammatory effect. because DGLA and EPA, that are omega-3 fatty acids, they stimulate the production of anti-inflammatory eicosanoids. And so they have an antipruritic and anti-inflammatory property. This is a small study showing this efficacy. In this study, there were 3 groups of 10 animals each, and one group was given mineral oil as a placebo. One group was given EPA and DHA, that are omega-3 fatty acids that are anti-inflammatory. One group was given LA and ALA, that are omega-6 fatty acids that are high in the metabolic chain and that are not as much anti-inflammatory, but they are improving the skin barrier. And you can see that in the placebo group, only 2 dogs improved and no dog was in complete remission, and that is the 20% placebo effect that I was mentioning before. In the dogs that received omega-3 fatty acids, 5 improved more than 50% and 3 achieved a complete remission. These are the anti-inflammatory essential fatty acids, and in the group that received the essential fatty acids that would improve the skin barrier, we also had 4 of these dogs that improved by more than 50%. So the clinical scores of treated dogs improved significantly if compared to the placebo, while the owner's evaluations were not significantly different. So we do know by studies, and this is one study, that the diets improve the skin barrier. There are diets that can really improve the lipid contents in the stratum corneum. This diet that has been used for this study was containing products like nicotinamide, pantothenate, histidine, inositol, and choline. They are all products that are very good for the skin. This diet was given during the pregnancy and to puppies up to 1 year in animals that were at very high predisposition to developing atopic dermatitis. And in these dogs that were taking the diet, they actually got a decreased production of allergy to DERF, that is dermatophagoides farine, and that is the house dust mite, and they had a decreased development of atopic dermatitis compared to the dogs that did not get the diet. So it really helped improving the coat, the skin barrier, and it really helped decreasing the development of atopic dermatitis. We know that diets also improve pruritus and inflammation thanks to their content in mainly essential fatty acids, and we have many articles that show this. So I think that including the skin diet in our multifactorial therapy is something that we can do very easily because the animal has to eat, so there is no stress for the owner to buy one diet or another diet, and it can really help improving the whole situation. So if we want to do the follow-up of Boston, we can say that, in fact, the owner refused allergy testing and allergen-specific hyposensitization due to cost, I guess. And he thought that he would use oclacitinib as a reactive therapy. We gave it for 3 weeks. And then he accepted to do an all-year-round strict antiparasitic control. And he was given a skin diet. As I said before, this is very useful for the barrier function. This is very useful to decrease pruritus. And we used Purina DRM, which is an excellent skin diet, as a maintenance therapy for the whole life of the animal. And in order to block the pruritus in a proactive way, once that we had eliminated all the infections, When we stopped oclacitinib, we tried the use of antipruritic shampoos, topical mousses with ophitrium. Well, the allergy is never something that will stay under control forever. You may have moments of relapses, and when Boston has moments of relapses, we would use occasional oclacitinib tablets when needed. But giving a diet and giving topical antipruritic and anti-inflammatory products and giving a all year long antiparasitic protection was able to maintain Boston well in remission for most of the year. And with this, I thank you very much, and I hope you enjoyed this quite long lecture on Boston and his atopic dermatitis. Thank you all.